Bismillah Rahman Rahim. Primary angle glaucoma. Now we'll discuss primary angle glaucoma under the headings of pathogenesis, classification, and then different types of glaucoma, that is intermittent, acute congestive, post-congestive, chronic. Now what is the difference between open angle glaucoma and closed angle glaucoma? I'll try to explain it by the help of diagram. Well, this is the shape of eye. Here is the optic nerve. This is angle of the anterior chamber. This area, this is angle of the anterior chamber. Now, if in this particular case the angle is open, means the angle is something like this. Now, if this iris, it is attached to the lens and this angle is closed, we call it angle glaucoma. I will draw it again like this. Here the angle is open on one side and here the angle is closed. So this is relatively open angle and this inferiorly this is relatively closed angle. So that is the difference between open angle and closed angle glaucoma. What is the important difference? First of all, so that is just an academic discussion whether the angle between iris and the cornea is narrow or it is not narrow. So that is, I mean to say, is just an academic discussion. But what I want to stress is basically they present in entirely different way. Open angle glaucoma, which you studied last time, is also called silent thief of the vision. वो नज़र को आहिस्ता आहिस्ता खामोशी से चोरी से ख़त्म कर देता है. That is the silent thief of the vision. There are no symptoms. Patient does not notice anything. Very intelligent patients, they notice that the field of vision is decreased. But most of the patients, they do not notice any change in their vision because central vision is retained till very late stages of the disease. But in angle glaucoma, there is sudden rise of intraocular pressure. With sudden rise of intraocular pressure, what happens? That first of all, the bare nerve endings in the cornea, they are not used to raise in intraocular pressure, and because of this, the patient, they feel severe pain, which is not in open angle glaucoma. In open angle glaucoma, there is very slow rise of intraocular pressure, and because of this very slow rise of intraocular pressure, the nerves, they become used to raised intraocular pressure and no pain is felt by the patient. Secondly, the corneal endothelium. Corneal endothelium, it's a very important and metabolically active structure. What happens? In angle glaucoma, there is sudden rise of intraocular pressure and the endothelium of the cornea, it is not adjusted with raised intraocular pressure, it gives way. And the function of corneal endothelium is to keep the cornea dry, to pump fluid out of the cornea, and if the functions of endothelium are disturbed, then there is edema of the cornea. And because edema of the cornea, the vision is decreased. So I repeat, in primary angle glaucoma, what happens? The vision is decreased. Patient reports to you with severe pain. Along with pain, there is redness, there is watering of the eye, severe pain in the head, and sometimes there is vomiting also. Patient is restless. So patient comes running to the clinic of the doctor to get treatment, which is not so in open angle glaucoma because the raised intraocular pressure is very slow. Okay? So the difference between open angle and closed angle, first of all, the pathology, secondly, symptoms and signs. Now what are the risk factors? Number one, with increasing age, there are more chances. Then it is more in the females and in Chinese ethnic origin. Why? Because in females, as compared to male, their height and size of their structures are smaller. The size of the eyeball is smaller. Because of smaller size of eyeball, there is more approximation of iris and the cornea. That's why there are chances of closure of the anterior chamber angle. Similarly, Chinese, the Asians or Chinese, they are smaller in size than rest of the races. That's why there are more chances of having them closed angle glaucoma. Similarly, the family history is also important. Now, what are the anatomical factors? Again, the same thing, shallow anterior chamber depth. If the anterior chamber depth is shallow, there are more chances of angle closure. Then, the thick anteriorly positioned, either lens is thicker or it is positioned anteriorly. Short axial length is the same, small size of the eye, small diameter, increased curvature of the cornea, and sometimes plateau iris application, that is, iris is inserted anteriorly on the ciliary body, causing decrease in the depth of anterior chamber. Again, now this is convex. You can see this is the cornea and this line is passing over the iris and the lens is convex and thick. That's why the anterior chamber depth is shallow. Again, anterior chamber is shallow. And third, there is narrow entrance to the chamber angle. Again, lens size is large, corneal diameter is smaller, and axial length, that is, eye is smaller in size. Now, what are the factors which precipitate? First of all, in dim illumination. In bright light, the pupil is constricted. When pupil is constricted, though it is approximated with the lens, but the maximal curvature of the lens is at the mid periphery. So mid periphery is avoided either in constricted pupil or fully dilated pupil. That's why in primary angle glaucoma, if the pupil is constricted or fully dilated, it is not precipitated. But if the pupil is mid dilated, that is in dim illumination, the attack is precipitated. Then there are certain drugs, most importantly are the atropine or dilated mediatic drugs. Then emotional stress. If there is excruciating pain, it leads to mydriasis, dilatation of pupil, and when the pupil is mid dilated, there are chances for having this attack. I will show you.
A small percentage of people with glaucoma have a condition known as narrow-angle glaucoma. This type of glaucoma can occur slowly and progressively, or very quickly, and can only be detected through a comprehensive eye exam. Narrow-angle glaucoma usually occurs in far-sighted people because they tend to have anterior chambers that are smaller than normal. In cases of narrow-angle glaucoma, The iris can bow forward, thinning the angle that normally drains the eye. As the angle becomes smaller, fluid backs up, and pressure in the eye or intraocular pressure begins to rise. If narrow-angle glaucoma is not diagnosed and treated, it can cause loss of vision. In some cases, narrow-angle glaucoma can lead to an emergency condition known as angle closure glaucoma. For more information, ask your doctor about narrow-angle glaucoma.
Now we'll discuss, now you have seen that the fluid, it is formed at the ciliary body, pars placata of ciliary body. From ciliary body it goes into the posterior chamber. From posterior chamber it goes into pupil of the eye. Through pupil it goes into anterior chamber. And from angle of the anterior chamber it is drained out of the eye, and that angle of the anterior chamber is closed in angle closure glaucoma. Now we'll again discuss the pathology at the level. So the pathology, it is at the maybe at the level of pupil or iris, or it is pushed by the lens, or it is pushed from by something behind the lens. So that is the level of pathogenesis. Now pupil block. On the laser pointer. Well, now it is in the mid dilated position. Pupil is in the mid dilated position. This is lens, this is cornea, and this is iris. In the mid dilated position, this iris, it is approximated with the interior surface of the lens. Because of this is the fluid which is formed at the ciliary body. So there is no place for fluid to go. So it will try to go through the pupil, but pupil is blocked. So it will push the iris forward. This forward push of the iris is called iris bombae. Iris bombae. And this increased pressure in the posterior chamber. This push of the iris, forward curving of the iris towards the cornea, it narrows the angle of anterior chamber, and this is the angle of anterior chamber. And because this narrow angle of the anterior chamber, after some time this is blocked. Now there is no place for pupil to go. If we don't treat it in time, this will be totally blocked and there will be synecdoche formation. So there is sudden rise of intraocular pressure because of all this, and because of a sudden rise of intraocular pressure, again I repeat, there will be pain, there will be redness, there will be decreased vision, there will be watering. So all these things happen. Now classifications are also based on at the level of iris. Then one was the block at the pupillary level. Second is at the level of iris. There is thick peripheral iris. Then if there is a membrane, neovascular glaucoma is when new blood vessels they form on the surface of the iris because of ischemia in the retina most of the time. Because of ischemia in the retina, new blood vessels are formed on the surface of the iris, and these blood vessels then grow on the trabecular meshwork, and they also grow on the cornea. When they contract, a membrane is formed and the angle is closed. Then again in uveitis, in inflammation, same things happen. Then on the iris, sometimes ciliary body, it is rotated anteriorly, and that's why the iris which comes out of the ciliary body, its direction is toward the cornea and the angle is closed. Then pathology at the level of the lens. I'll try to show you. Now, cornea. Sorry. Now, this is iris, and behind iris is the lens. So, if this lens like this. Now, if this lens it is thick due to any reason, it will push the iris forward. Or if its zonules are broken and it goes into the anterior chamber, or it blocks the pupil. So it can push, why? When lenses become thick, I'll show you. The lens becomes thick in phacomorphic. Morphic structure, phaco means lens. It is in the initial stages of cataract formation, and sometimes in intermittent stage of cataract formation, there is thickening of the lens. Then phacotopic. Topic means location. If lens is not at its normal position, it is subluxated, or it is interiorly positioned lens, or the subluxated lens in many diseases, the zonules are weak and lens is not present at its usual location. These are called not subluxed, subluxated lens. So this is because of trauma or because of a disease called pseudo exfoliation. All these things, in all these diseases, there can be problem with the lens, and it can push the iris forward, decreasing the distance between iris and the cornea and causing angle glaucoma. Now, how we are going to classify? First of all, the easiest classification is based on the symptoms. Few glaucoma specialists, they don't agree with it, but I still believe that it is the simplest, easiest to remember. First of all, latent or glaucoma suspect. Second, subacute or intermittent angle glaucoma. Third is acute congestive glaucoma, then chronic glaucoma, then absolute glaucoma. Now, latent glaucoma or glaucoma suspect. In this, IOP is normal, but on gonioscopy you see that the angle of the anterior chamber is very narrow. There is family history of some near relative, or the patient's eye is very small in size, then you can suspect that patient can have glaucoma in future. Second is intermittent angle glaucoma. As I told you, that if the patient is in a situation that is dim light, means in the evening he comes back and he switches off the light and starts watching TV, the pupils are in mid-dilated position. And in mid-dilated position, there can be rise in intraocular pressure, there can be block at the pupillary level, and there can be a rise in the intraocular pressure. If there is a rise in intraocular pressure, the patient will have symptoms. But if he changes position, switches on the light, or goes to sleep, then what happens? That the pupil either constrict or dilate, and that blockade is released. If that block is released, then the patient is symptom free. So that is called intermittent angle glaucoma. So this intermittent angle glaucoma, it goes into or may change into acute congestive glaucoma or chronic glaucoma. So if such angle closures they occur frequently, then what will happen? That synechys will form between between iris and the cornea. So that is very slow formation of synechia. We can call it creeping angle closure, and there is slow rise of intraocular pressure, which again may lead to uh, chronic angle-closure glaucoma. The signs and symptoms of chronic angle-closure glaucoma are just like that of open-angle glaucoma. Third, and most importantly, are the acute congestive glaucoma. In acute congestive, there is sudden total angle closure. There is sudden raise of intraocular pressure. There is a pain. There is redness, and it does not resolve until and unless you treat the patient. Either you do give medications, or you apply laser, or you do surgery. Otherwise, there is very severe pain. Then chronic means it from intermittent angle closure glaucoma, it can go straight into chronic angle closure glaucoma. And absolute glaucoma is a term used when the vision in the eye is totally lost, the eye is hopeless, we call it absolute glaucoma. Now, second is classification based on natural history. So that is slightly different. In which primary angle closure suspect, PACS, second primary angle closure, third is primary angle closure glaucoma, PACG. This is not, I have written by mistake PACC, it is PACG. So basically, in suspect, the angle is narrow and iridocorneal contact, iridotrabecular contact less than 180 degree of trabecular meshwork is visible on gonioscopy. And in primary angle closure, more than 180 degree of trabeculum is closed because of closed angle. There is damage and there is high intraocular pressure. In first one, the intraocular pressure was not high, and this PAC, the intraocular pressure is high. And in primary angle closure glaucoma, that was primary angle closure, this is primary angle closure glaucoma, there is one additional thing, that is there is also cupping of the optic nerve. I repeat, primary angle closure suspect means the chamber, angle of the anterior chamber is shallow, and we do gonioscopy. On gonioscopy, we find that less than 180 degree of trabecular meshwork is visible. In primary angle closure, there is also raised intraocular pressure, and thirdly, in third, all both things, plus there is cupping of the optic disc. So this is intermittent angle closure glaucoma. During the attack, epithelial edema and closed angle, and after the attack, after bilateral jag iridotomy is done, or after the attack subsides due to any reason, the cornea it becomes clear. Now, provocative test, that we try to recreate artificially the situation which induces the angle closure, attack of angle closure, that is in the prone position, in dark room, we call dark room prone position, or water drinking test, or we give mid-dresses, we dilate the pupil. All these things, these provoke the closure of angle of anterior chamber. That is dark room prone position, in a dark room mid dilated position. We ask the patient not to go to sleep, because in sleep the pupil are dilated, and if there is a chances of attack, they will subside. So we want to induce the attack, we want to provoke the attack. So to provoke the attack, we ask the patient to lie down prone in a dark room and not going to sleep, or we dilate the pupil. When they are mid dilated position, we examine the patient, and third, we ask the patient to drink a lot of water, and because of lot of water, there is raised intraocular pressure. Now, symptoms of acute congestive glaucoma, as I told you, acute congestive glaucoma, it's a medical emergency, needs immediate treatment. There is rapid decrease in vision, there is severe pain, I told you, and there may be nausea and vomiting, eye is red, intraocular pressure is high, corneal edema with bullous formation or epithelial vesicle. Interior chamber is shallow. As I told you, pupil is fixed in vertically oval and mid dilated position. Now this is sorry, this is corneal edema. We cannot see the margins of the pupil. The pupil is dilated, mid dilated, vertically oval. Again the same thing, severe corneal edema. Because of edema, there is a haze. We cannot see clearly the margins of the pupil. There is ciliary injection. Interior chamber is shallow. There is one line on the iris, other is on the cornea. There is shallow interior chamber. Then there is closure, complete angle closure. What is the treatment? First of all, we will reduce the intraocular pressure with whatsoever means are available. That is, we give acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor so that intraocular pressure is reduced. Hyperosmotic agents are given. Again, because osmotic level in the ciliary body becomes high, and because of osmolar gradient, fluid will come in from anterior chamber into the from posterior chamber into the ciliary body. So it will decrease the production of aqueous. Then we constrict the pupil with pilocarpine. Beta blockers are given to reduce production of aqueous, and steroids are given to relieve pain and to decrease redness. Then Jack laser iridotomy is done. We make a hole in the iris so that fluid, if the blockade is at the level of pupil, because of the hole in the iris, the fluid, it comes from posterior chamber through that hole into the anterior chamber and is drained via trabecular meshwork.
Laser iridotomy is a type of laser surgery for people who have or who may develop narrow-angle glaucoma. A laser is used to make a small hole in the iris, the colored part of the eye. This hole should restore normal flow of fluid within the eye and reduce the eye pressure.
You have seen the surgeon with the help of Jack laser made a hole in the iris because the pupil was blocked. The aqueous was unable to pass through the pupil into the anterior chamber, so an other opening was made in the iris so that the aqueous, it can pass from the posterior chamber into the anterior chamber, and then the iris bomb is relieved and the pressure is decreased. Now, what is the differential diagnosis? Acute rise in intraocular pressure. First of all, again same thing, lens induced glaucoma. Second is malignant glaucoma. Lens induced glaucoma means the lens is increased in size because of cataract. And if it is increased in size because of cataract, then it is called lens induced glaucoma. Malignant glaucoma, it is a term used when there is misdirection of aqueous. Instead of coming into the anterior chamber, it goes through from the sides of the lens through the zonules into the vitreous. So this is called malignant glaucoma. The pressure is increased. Neovascular glaucoma, these new blood vessels, they are formed. These new blood vessels are found on the iris, then on trabecular meshwork, and again they cause raised intraocular pressure. Then pigment dispersion, that the pigments of the iris, they are very weak. So with each movement of the iris, they come out of the iris and are floating freely into the anterior chamber, and because of this pigment dispersion, again the pressure, it becomes high. Now these are the signs of the post-congestive angle. After the attack of angle closure is relieved, you can see the patient with folds in the descemet membrane, stromal iris atrophy, folds in the descemet membrane, the iris atrophy, fixed dilated pupil, posterior synecdoche can be formed, folds in the descemet membrane, but this is not very important. And Finally, optic atrophy. Because of repeatedly or raised intraocular pressure for long period of time, there is optic atrophy. Now, chronic angle glaucoma, it is similar to primary open angle glaucoma, but if you do gonioscopy, you will see that whole of the angle is closed, unlike open angle glaucoma. That's why the treatment is the same. That is, in chronic open angle glaucoma, again you will need trabeculectomy. That is, forming an artificial hole, artificial passage between anterior chamber and subconjunctival space. Thank you very much.